Hi, everyone. I'm Volkan Yumuk. I'm a clinical endocrinologist, and today I'm representing the European Association for the Study of Obesity. As you see, this is a joint meeting with a sister society that is the European Renal Association. And the topic we chose is fatty kidney, which is a very interesting topic, open to clinicians and for researchers. Our first speaker is Trond Jensen from Norway. Professor Jensen is a senior consultant in the Department of Transplantation Medicine section of nephrology, University Hospital of Oslo, Rikshospitalet Hospital. He's a professor in kidney disease, Faculty of Medicine, University of Oslo, professor of internal medicine, Department of Health Science, Arctic University of Norway, Tromsø. His recent contribution to practice, occurrence of diabetic nephropathy after renal transplantation despite intensive glycemic control. Trond, the floor is yours.
Thank you very much, Volkan, and thank you also to the association for inviting me to this meeting. I have the pleasure of talking about adiposity and overweight in kidney disease, actually. And this is part of a discussion that we had in the obesity group, which is part of the European Renal Association back in September this year. So before I proceed with my slide deck, I just want to give you my conflicts of interest that may be relating to this talk. The next slide, unfortunately, is with Norwegian text, but it gives you just the outline of what we are talking about in terms of kidney disease. Each kidney actually consists of about 1,750,000 microkidneys, the so-called nephron, with the glomeruli here and the tubular system more distal to the glomerulus. Each kidney with about 750,000, 1 million nephrons, 2 kidneys altogether, 1.52 million nephrons. And every time you see a patient who has declining renal function, that is because there are nephrons disappearing and the other nephrons will have to take over the work. So the main part of my talk is going to be related to in terms of obesity and kidney disease, it's going to be relating to the phenomenon of hyperfiltration. This is just a drawing of the nephron, the glomerulus to the left. And here you can see the proximal tubulus with a nowadays very famous SGLT2 reabsorption system of glucose and sodium, and then the more distal tubular system. We are in a position that even if glucose is filtered from the glomerulus, most of it is reabsorbed proximally in the proximal tubules, so we actually produce no glucose in the urine. There are at least 3 instances where hyperfiltration in the glomerulus can take place. One is, as I just said, that nephrons are falling apart, they are disappearing, and maybe 60% or 50% or 40% of the nephrons will have to take over the work. That will naturally lead to hyperfiltration in the remaining glomeruli. The other reason which may complicate this and even increase hyperfiltration will be diabetes with hyperglycemia. If you have hyperglycemia, you filtrate more glucose into the tubular system. More glucose is reabsorbed together with sodium in the proximal tubules, and that makes changes in the sodium flux in the Henle's loop, which actually leads to dilation of the afferent arteriole in the glomerulus and also hyperfiltration. So not only few nephrons, but also hyperglycemia by itself will lead to hyperfiltration. The third reason could be that the body mass increases. So with obesity, there will be an increased filtration challenge for the remaining glomeruli. And this, of course, will be deteriorating and even more expressed if the patient not only has obesity, but also diabetes and maybe even fall in GFR, which means loss of nephrons. So that is the picture that we're going to talk about. If you want to have some insight into the concept of hyperfiltration, this is the famous paper by Barry Brennan and co-workers back in 1996, which actually presented the concept of hyperfiltration as a cause of kidney disease, at least when kidneys are failing and GFR is falling. Now, there's another important paper I want to focus on, and just to mention this paper in the beginning of my talk, a review paper back in 2016 by Dagati and co-workers in Nature Reviews Nephrology. This is a very detailed and very good paper describing what can happen in obese persons with damage or deteriorating kidney function. The main thing is actually that when you have obesity in a patient, not overweight, but rather obesity, there's an increased filtration challenge in the glomeruli. So these are actually biopsy pictures from obese and non-obese persons, taken for some other reason. But you can see that in the obese person, the glomerulus looks enlarged, it's hypertrophic, as compared to a non-obese person with a more normal size glomerulus. And you can even see here down at the bottom of this glomerulus from the obese person, it looks like there's some hypertrophy in the arterial wall. And the changes may be even more expressed inside the glomerulus with segmental sclerosis when glomerular changes take place when this hyperfiltration stands over time. And to the right, you have also an enlarged glomerulus from an obese person, and you can see a dilated arterial with hypertrophic walls that may indicate that hyperfiltration, hyperplasma flow is taking place. What is the mechanism behind this? Well, we know also in the kidneys that there may be ectopic fat deposition, but these are mainly studied in animal models because we do not really have any non-invasive method of studying lipid deposition in kidneys in real life in humans. But this paper actually presents some interesting mechanism that I will come back to during my talk and by the end of the talk. They discuss the probability that lipid toxicity and maybe lipid effects may take place also in the kidney, not only in the fatty liver and other places with ectopic fat deposition. Triglycerides may actually be a common denominator here. Increased triglycerides in epithelium of the tubulus or even in the podocytes, the epithelial cells of the glomerulus, and also in the mesangium surrounding the capillary vessels. Increased deposition of triglycerides into the kidney may be caused either by increased fatty acid synthesis, increased fatty acid uptake, decreased fatty acid oxidation, or decreased lipolysis. And this is part, as I will come back to, probably to as a picture in the metabolic syndrome, where hypertriglyceridemia may take place as a rule of the thumb. Now, going back to obesity as total body obesity, the original notion was, as you can see, already back in 2006, that BMI may be detrimental. At least it's associated with increased risk of end-stage renal disease. This is a huge population study from Kaiser Permanente in the United States. Altogether, 320,000 persons studied for a total of more than 8 million person years, which means an average follow-up of about 20-25 years. And they could record 1,471 cases of end-stage renal disease during follow-up. And as you can see here on this x-axis, with a reference for the risk of end-stage kidney disease being with a BMI between 18.5 and 25, there is a progressive increase in the occurrence of end-stage kidney disease with increased body mass index. So that sort of supports the notion that increased body mass as a whole will be detrimental for the kidney function over time. We do not believe, I think, that obesity itself will cause kidney disease, but obesity itself could sort of be progressive for kidney damage that is there already, maybe because of hypertension, diabetes, or other kind of kidney diseases. However, not all studies can confirm this finding that body mass index is a major factor being associated with decreased renal function and end-stage kidney disease. In the Framingham study, for instance, they could not confirm these findings. Fewer persons, I admit, but they studied the risk of developing stage 3 kidney disease, which means GFR less than 60, meaning that kidney function is reduced by at least maybe 40% in these persons. And as you can see here, in several subgroups, in the overall group to begin with, there was no clear association with overweight or obesity in these patients. And even if you studied subgroups like those without hypertension, those without diabetes, those without cardiovascular disease, same phenomenon. There was not an association with body mass index and the risk of developing stage 3 kidney disease. Later on, not later on, but a bit earlier, but this is a cross-sectional study, the PREVENT study from Holland by Pinto Sitzma co-workers, come up with a concept that maybe it is not the peripheral obesity that is detrimental for the kidneys, but maybe it's primarily the central obesity, not distinguishing, of course, between subcutaneous adipose tissue and visceral adipose tissue, but the central obesity seems to be more predictive of diminished renal function over time. So here you can see the correlation between increase in waist-hip ratio and the relative risk of diminished filtration among quartiles or waist-hip ratio. So this was a cross-sectional studies in patients without diabetes, and it made some of us believe that maybe it's not the obesity itself, the peripheral obesity, but maybe more obesity related to the central part of the body. And this was also confirmed in a follow-up study, a rather large follow-up study published from Boston in the United States back in 2008, the so-called atherosclerosis risk community study. Studied 30,000 persons with a mean follow-up of 9 years, and they looked at the incident decrease of eGFR of at least 15 mL per minute corrected for body surface or developing stage 3 kidney disease. And as you can see from these two graphs, there is no relationship between body mass index and the risk of developing decrease in GFR, but there is a linear relationship between waist-hip ratio and the phenomenon of decreased renal function. And this leads me to a paper that is standing on its own feet, but has been forgotten by many endocrinologists. Personally, I'm a nephrologist, but with a special interest in diabetes and metabolism. And what this paper says is that they studied actually altogether 1,146 white men and women, a study published in Journal of Clinical Investigation in 1997, and all these 1,136 persons underwent state-of-the-art hyperinsulinemic euglycemic glucose clamps. They collected data from altogether 20 clinical research centers in Europe and put them all together. And the conclusion here in this paper is, if you look at more or less healthy persons, but with overweight or obesity, you will find, if you use as reference those with the most insulin sensitivity, the 10% most insulin sensitive persons, you can see that there is, of course, increased occurrence of insulin resistance with increased body mass index. But as a whole, only 26% of all obese subjects were insulin resistant. And in this paper, 60% of subjects with BMI above 35 were insulin resistant, meaning that 40% of these persons were not insulin resistant. So BMI is, of course, and you may know that from before, but it's rather good, rather news for the nephrology colleagues that I have, that BMI itself does not determine that the person is insulin resistant. We had to look other places. These are the graphs of the same phenomenon. It's the plasma insulin concentrations in black columns, and it is insulin sensitivity in the light columns here. And you can see that it increases with increased body mass index, but even at body mass index above 35, only 60% of the persons will be insulin resistant. And this has, of course, to do with the type of adipose tissue that you are looking at, not what we tend to call the healthy, in brackets then, healthy obese persons with subcutaneous deposit of fat with normal fat cells. We are talking about those with visceral obesity and inflamed and pathological fat cell metabolism. I don't want to go into more detail into this, but you know the whole story, of course. So primarily, we also in kidney disease, we may be looking at these persons rather than these persons. And I will go further into detail on this with new information. But I start off with this paper from 2007. This is a study on young persons, on average 18 years of age. 1,500 persons studied with estimated GFR, a creatinine clearance formula, Cockcroft-Gault, and they looked at the correlation between increases in metabolic risk factors, 1, 2, 3, 4, blood pressure, HDL cholesterol, triglyceride, glucose, increases in the occurrence of these 4 risk factors compared to creatinine clearance estimated by the Cockcroft-Gault formula. And all these persons have normal renal function or above renal function. And you can see here from the graph that with increasing numbers of risk factors that we have to the left, with increased numbers of risk factors, there is a true increase in GFR. The more metabolic risk factors you have, the more you will filtrate. And this is what we call hyperfiltrations, because the reference group has a normal creatinine clearance rate. So metabolic risk factors are associated with the degree of hyperfiltration, not only the body mass itself. And this is a study from my home university, University of Tromsø, that I originally was affiliated with, and I was part of this group. This group had the ability to follow 1,600 persons with measured GFR, not only estimated GFR, but more accurately measured GFR over time, and in the Tromsø Health Service. This is just one of the waves of the Tromsø Health Service, a study taking place between 2006 and 2007 and 2009, in altogether 1,555 adult persons, measuring GFR with an iohexol clearance technique and looking at the relationship between measured GFR and waist-hip ratio. And I can tell you that there was no relationship to BMI, but there is a true relationship to the waist-hip ratio and the degree of filtration rate. So this is more a hyperfiltration tendency that you can see here. Those people at the left end of the scale may be sort of borderline nephropathic, I guess, but this is true hyperfiltration to the right. And the same group published later on a follow-up study, 5.6 years follow-up in persons who were also measured according to metabolic risk factors. This study was studied after exclusion of, for several reasons, of persons in the same, this is the same survey actually, they ended up following or assessing 1,261 persons after 5.6 years and looking at what could be associated with the GFR in these patients after 5.6 years. There was certainly no real correlation between body mass index and even Austin waist-hip circumference here. But even with those different models here for adjustments, you could see here that what really tended to sort of predict glomerular filtration rate decline in this population was actually metabolic risk factors establishing the metabolic syndrome and especially the triglycerides. So this leads us back to the original paper by Dagati and co-workers who looked at animal experiments, even in human cohort studies, we can find that there may be a relationship between metabolic risk factors and triglyceride more than to body mass index itself in terms of predictive decline in renal function. This is another paper more recently, a huge paper from Austria, a huge population base, I would rather say. 176,420 persons, half of them women, mean age 43 years, followed for a mean of 22 years. And they looked at the risk of end-stage kidney disease in this population, which occurred among 454 of the participants. They constructed and evaluated a triglyceride glucose index, which is sort of an insulin resistance index, calculated as a logarithmic values of the triglyceride times the blood glucose values in milligrams per deciliter. And what they found was that the risk of end-stage kidney disease was actually pretty much determined by the triglyceride glucose index. You can see here from the quartile with the lowest triglyceride glucose index to the increased levels that you have a real tendency, a risk of developing end-stage kidney disease, even if you correct not only for age and sex and smoking status, but also BMI itself. So this was sort of a paper that was published in JAMA in 2021. And the same group looked at a subgroup of these 170 persons in a study published just this year in the Journal of American Society of Nephrology. And this paper included 100,269 subjects, mean age 46 years, followed for a mean of 23 years. And what they wanted to look at with all these differences in BMI, how could overweight, obesity, BMI be related to the development of end-stage kidney disease? They corrected for age, sex, smoking status, socioeconomic status, and they looked at 3 factors that may relate it to the metabolic syndrome. Insulin resistant, determined by the triglyceride glucose index, hypertension, hyperuricemia, and also a cholesterol index or measurement that they performed. And what they found in this study was that what could determine the development of end-stage kidney disease was not the BMI itself, did not have an impact of the development of end-stage kidney disease, but rather the triglyceride glucose index, a surrogate index for insulin resistance. Blood pressure had an effect, or was actually associated with, I should say, also uric acid, but not total cholesterol. So again, it is sort of more or less the metabolic components of central obesity, visceral fat, rather than body mass index itself, that may contribute or predict loss of renal function. Again, I cannot say that these factors make up or produce kidney disease by itself, but for certain they will be detrimental and more progressive for kidney failure, nephron loss, if you have a kidney disease already from other reasons. Finally, my third last slide would be that it is not unimportant when in life you develop your obesity or your overweight. This is a study on overweight, actually not obesity, but on overweight from England. They looked at a certain cohort that was born during 1 week in 1946. They had follow-up complete data from 1,800 participants, but they used imputation to expand the numbers to 4,500 participants. And they looked at how did overweight, meaning BMI between 25 and 30, predict a decrease in renal function, estimated GFR less than 60, or increased urine albumin creatinine ratio above 3.5 at aged 60 to 64 years. And what you can see is that the risk is really largest if you develop your overweight in your young age, when you're 26 years, also when you're 36. This is all compared to if you produce or get your overweight at the age of 60 to 64, or you are lean. So being overweight at age 26 being overweight at age 36 and maybe less so in the mid-age, will sort of predict that your GFR will be lower in the long run. So the durability of overweight is also important, of course, not only the degree of overweight by itself. So let me just summarize to you with some conclusion that obesity is associated with glomerular hypertrophy and segmental glomerulosclerosis, and hyperfiltration may certainly be one mediating mechanism. However, central obesity, and I should probably say visceral obesity, is more closely related to glomerular decline than whole body obesity itself. And whole body obesity is not necessarily related to the insulin resistance syndrome. And certain components of the metabolic syndrome, such as blood pressure, uric acid, and also surrogate measures of insulin resistance, for example, triglycerides, may predict glomerular decline more strongly than overweight itself. So my final conclusion is, in terms of kidney disease, you should also be aware of your triglycerides. And that concludes my small talk here. And this is Bob Dylan back in '64. It's not the picture of Bob Dylan, but the times they are changing. And we are looking at central obesity these days more than we did in the old days. Thanks a lot for your attention.
Trond, thank you very much for this excellent presentation. And I think we would have some questions for you.
Okay.
So I think you can also see the chat area, but and the first question from Abdulhamid, he says, is it obesity or metabolic syndrome related kidney disease that is we should be talking about, or both?
Yeah, it's a good question. From what I've been presenting and my own thought, given that I went through the literature this summer, is that obesity may be detrimental in some circumstances, but actually the mechanisms, I think, rely more or less in a metabolic syndrome. What you can see if a person undergoes extensive, at least significant body weight loss, being obese, let's say more than 10% loss in body mass index, is that the degree of proteinuria decreases significantly, which is a measure actually of improved renal health. But at the same time, you also improve the same person's metabolisms. And if you look at if you look at animal studies and what I presented from these cohort studies, it seems to be the metabolism related to obesity, and especially the central obesity, that is important, more important than total body mass itself. And maybe I could comment on the SGLT2 inhibition as well from the same questioner, because I think that SGLT2 inhibition will be beneficial obesity-related nephropathy. We do not have studies on this. We only have studies on kidney disease in general, and especially diabetes. But what SGLT2 inhibition does is that it sort of reduces the glomerular hyperfiltration, which I think is detrimental and a working mechanism in this kind of nephropathy. So I would suggest that SGLT2 inhibition will work beneficially in these persons. We know it works in diabetes at least, and it seems from sub-studies in these trials that it works at all different degrees of BMI.
His third question is whether we should be looking for insulin resistance parameters like measuring HOMA-IR in non-diabetic people living with obesity.
Yeah, I've been thinking the same question myself, and I come to my own conclusion that it's a very important thing to look at in studies in groups of persons, but I don't think it's so accurate on an individual basis that you could use it in a daily clinic on an individual patient. Personally, I think the most sensitive parameter of insulin sensitivity or resistance that you have in the clinic is actually the level of fasting triglycerides. If you have an otherwise non-diabetic persons, but fasting triglycerides are elevated without any obesity at least at present, then I think you have an insulin-resistant person in front of you, just by looking at the triglycerides.
Okay. Sandra asked a question. What is the effect of the bariatric surgery on the hyperfiltration and end-stage kidney disease?
I don't know if we have studies on end-stage kidney disease at the outcome, but studies show that if you undergo bariatric surgery with extensive weight loss, more than 10%, more than 50, maybe 15, 20%, you sort of decrease your hyperfiltration extensively, maybe to a normal range. The degree of proteinuria reverses and GFR tend to stabilize. You may not cure the patient, but that may be in some circumstances a delay of the need of dialysis and transplantation for up to 15, 20 years, I guess, provided you start with a GFR above 40 or 50.
Hema asked a question that I was going to ask, and that is, aside from the insulin resistance and the role of, she's asking the role of fat, which is perirenal fat or renal sinus fat.
Yeah.
The role of this accumulation, ectopic accumulation.
It is an exciting question, and I don't really have the answer of the role of it, but tend to hypothesize that it has a role that may be quite similar, or at least resemble what you can see in fatty liver disease, non-alcoholic fatty liver disease. Again, to get excess of this fatty acid, it's renal-related fatty tissue, you need to do biopsy studies, and we don't easily do that in native kidneys. We do them in transplanted kidneys because transplanted kidneys are easily accessible in the loin, but we don't do them in a protocol, in a research protocol situation. So for the time being, we know from animal studies that this is an ectopic kind of fat tissue that produces inflammatory substances and all the other factors that may relate to insulin resistance syndrome, as we can see with ectopic fat elsewhere in the abdomen. But human studies are lacking on the phenomenon.
And this question is also related with the ectopic fat mass in kidney, and that is, how can we pick up, are there any efficient imaging techniques that we can use?
Yeah, I think you can pick it up by MRs, but we do not use them in a daily clinics. But there are MR studies performed looking at this, and they are related to, it looks like in small groups of patients, this is related to kidney damage. But then again, in terms of GFR and albuminuria, but again, you don't know how it started. It may be, as I said, that this is more or less provocative or permissive for a progressive kidney disease that starts with something else. But it is of importance, I think. MR technique is probably the most invasive technique that we have, non-invasive technique we have today.
And the last question is in regards to GLP-1 receptor analogs, receptor agonists versus possibly this is sleeve gastrectomy, bariatric surgery, and long-term cardiac and kidney outcomes.
I'm not aware. I mean, the effect of GLP-1 analogs or receptor agonists on the kidney itself in huge trials is that they tend to reduce the degree of proteinuria. They do not to the same degree tend to stabilize GFR or prevent loss in GFR, but they do reduce the degree of proteinuria. It could be partly due to body weight loss and central obesity, because if you reduce body weight, you will have less hyperfiltration, that's for sure. I have to say that we do not have good studies on GLP-1 receptor agonists in GFR less than 60. So there are GFR studies going on now to see if it could be protective on renal function in patients with GFR less than 60. I think the similarity between GLP-1 receptor agonists and sleeve operation, gastric sleeve operation, is the body weight loss. And we have started figuring out just GLP-1 receptor agonists have a particular effect on the kidneys. And yes, it has. It has an effect of sodium transportation transport across the tubules, just like the SGLT2 inhibitor does, but on different places in the tubular system. And this is not present with the gastric sleeve operation. So bottom line, body mass reduction is the same, with the same degree of body mass reduction or central obesity reduction with those two initiatives. It will be the same benefit for the kidneys. But it could be that GLP-1 receptor agonists also additional kidney-specific effects that are related to the tubular system and the renal tissue itself. We don't know that yet.
Okay, Trond. I think we need to go to the second session due to the time.
Thank you.
That we have. And thank you very much for your presentation and the answers to all the questions, and the rest of the questions, if there are any, could be answered by the speakers that will be talking next to you. Thank you very much, Trond, and I think we'll see each other in the future in another meeting.
Yeah.
Or you can come to Istanbul for another congress or meeting, and we'll see each other. Thank you very much.
I'd be happy to. Thank you.
So you, Kathy, sharing is on me, okay. All right, so the second speaker would be Enrique Morales. He's a professor of nephrology, and he's from Madrid, Spain. And Enrique is the coordinator of a unit for complex adult glomerular pathology at the University Hospital 12th of October. He's a board member of the European Renal Association Obesity Working Group. His areas of research are hyperkalemia, obesity, renal diseases, glomerular pathology, lupus, nephritis, malignant hypertension, and acute thrombotic microangiopathy.
Well, Ken, sorry to interrupt, it's Ewan here. I think when you share your screen, you have to click a button that says share sound so that you can then hear the presentation as well. So I think you might need to unshare and then share again. And it's before you click the file, there's a button that says share sound.
Well, Ewan, this is...
Yeah, it's as soon as you press share screen, at the very bottom left-hand corner, there's a little tick box that says share sound.
Yes.
And then you select, the file after that.
Okay.
Thank you very much.
Is it working?
Invite me to participate in
Okay.
this interesting meeting. In this occasion, I'm going to talk about the link between NAFL or MAFL and CKD. This is my disclosure, and this is a common case report of our consultancy. She is a female, 53 years old, with obesity, and with this BMI, type 2 diabetes, hypertension, hypertriglyceridemia, and the patients with the chronic kidney disease with 45 GFR and proteinuria 1.2. And the imaging test with liver steatosis, and this is the score for 2.5. The question is, what is the relationship between two entities, chronic kidney disease and MAFL or NAFL? I tried during this talk to explain different aspects of this entity. First, I would like to talk about the importance of nuance in medicine. This is three painters with three pictures, but they use different colors to the same aspect, the skin. And this is very important in our patients because we need to individualize the treatment and the diagnosis in our patients. And there are some mistakes between the relation between two entities. NAFL is the most common cause of chronic liver disease in the world, around 25% of the general population, and increase this percent in different populations, such as metabolic syndrome or type 2 diabetes. NAFL includes different types of liver damage, from steatosis to hepatocellular carcinoma. NAFL is diagnosis by the presence of more than 5% fat accumulation in the liver cells. During the last decade, the main investigators are changing the concept of NAFL to MAFL because it included the metabolic syndrome with liver disease. Due to variety of metabolic comorbidities such as hypertension, insulin resistance, type 2 diabetes, dyslipidemia, central obesity, decided to change the name to NAFL to MAFL because included wide aspects of metabolic syndrome. In this picture, you can see the diagnosis necessary to non-invasive tests or score or imaging tests. Also, you know that the gold standard diagnosis is the liver biopsy. The hepatic steatosis patients who have exclude the secondary cause of hepatic steatosis, and finally the diagnosis is NAFL. And patients with obesity, or patients with type 2 diabetes mellitus, or patients with a normal weight and the present list 2 metabolic risk factor of this is the diagnosis of MAFL. You can see that the two entities, NAFL and MAFL, in the majority of the cases is the same aspect, but you can see in other locations we have some patients with diagnosis of MAFL or not NAFL. As you know, there are different comorbidities relationship between two entities. And NAFL is 20–30% of the adult population, and the patients with CKD the percent of population with the effects of this condition is higher than 25%. This is the different comorbidities are common between two illness: hypertension, dyslipidemia, obesity, and insulin resistance. You can see in the literature, some studies have confirmed that the presence of NAFL increases the risk of CKD, and that degree of liver fibrosis is related to CKD, while other studies have found that incidence of CKD is not affected by NAFL. Liver biopsy, you know, that is the most definitive approach, is the gold standard of diagnosis of NAFL and fibrosis in our patients, but we need to use other techniques to diagnosis of this entity. Non-invasive biomarker, different scores, you can see, or non-invasive imaging, MRI, ultrasound-based, or different techniques of the imaging to diagnosis of NAFL. What is the interconnection between NAFL, and CKD? The key questions regarding the link between these two conditions are: first, whether certain cardiometabolic risk factors are the basis of the association, or NAFL is self-made independently of certain cardiometabolic risk factors contribute to CKD development, or third, the CKD development risk is dependent of the degree of liver disease in patients with NAFL. In this slide, you can see the relation between NAFL and CKD. This is the different stages of chronic kidney disease, and these conditions compare between two entities: obesity, hypertension, dyslipidemia, diabetes mellitus, metabolic syndrome, and other aspects we can serve to contribute at two entities. During the next slide, I try to solve the different studies that solve the interconnection between NAFL and CKD. In this slide, you can see the different studies that solve the relationship or no relation between two entities. This aspect is very important because depend of the biomarker that you use to diagnosis of NAFL and the number of patients. In some occasion, no association between NAFL and CKD. In other occasion, increase the CKD in relation with the liver fibrosis in these patients. For example, this is an exam study about a cohort of patients, 80 patients, proving NAS with a liver biopsy and the control patients. And you can see on the left, the patients with CKD and normal albuminuria was a relationship with a NAS, and the degree of liver fibrosis was a relationship with the GFAR, with increase the fibrosis of the liver, decrease of GFAR. In other study, with the patients with chronic kidney disease, the prevalence of NAFL was around 18%, and the prevalence was most higher, near to 30% of the patients in diabetic patients. And the author saw the relationship between NAFL and the cardiovascular events. There was not relationship between end-stage renal disease and NAFL. This is a prospective study. The authors with important number of patients, they found a relationship between NAFL and increase of risk of chronic kidney disease during the follow-up of these patients. Recently has been published this manuscript of the Danish group of the patients, 290 patients with this cohort, compared with the control group. And this study, they found a similar prevalence with the CT, diagnosis of NAFL with the CT, in the cohort of patients with chronic kidney disease, in the cohort of controls for patients without chronic kidney disease. For this reason, they observed a normal prevalence of moderate and severe hepatic stenosis in patients with CKD, and nor appeared to be a risk factor for NAFL. In another cross-sectional study, they select different groups, 4 groups, depend on the exists 2 variables, or the presence of metabolic disease, or the presence of fatty liver disease. The most important aspect of this study was the patients with not fatty liver disease with metabolic dysfunction found a relationship with the risk of chronic kidney disease, and in patients with metabolic dysfunction and fatty liver disease, the relationship was higher than the group of only fatty liver disease without metabolic syndrome. For this reason, the conclusion of this study was MAFL was associated with the risk of CKD, whereas fatty liver disease without metabolic disbalance was not a risk factor for CKD. In summary, this different cohort study, NAFL is also a driving force for the development and progression of CKD remains of uncertain. This is 2 meta-analysis studies with an important number of patients. 11 cohort studies were included in this meta-analysis, and the conclusion of this first meta-analysis was that NAFL is associated with the increased risk of incident CKD independent of the established cardiovascular risk factor. In other meta-analysis with 13 observational longitudinal studies of different countries indicates that the long-term risk of developing chronic kidney disease states was increased in patients with NAFL, especially in patients that present liver fibrosis. In conclusion, this updated meta-analysis confirmed that NAFL detected by serum liver enzymes, fatty liver index, or imaging, was associated with nearly 40% increase the long-term risk of incidence of CKD. But the majority of this study has some limitation. The first not allow us to establish a causal association between NAFL and risk of CKD was uncertain with advanced fibrosis carry a higher risk of incidence of CKD than simple stenosis. Now, studies use the gold standard, the liver biopsy. The majority of these studies use BMI, but only in few of these studies additionally use their results for body fat distribution. This is a normal problem, common problem, was the use of MLD or CKD equations to calculate the GFR, neither of which are reliable in the presence of severe obesity or cirrhosis. Majority of this study was Asian studies and no large prospective studies. But what are the putative mechanisms linking NAFL with CKD? We are going to talk about different aspects from RAS defects to sustain chronic inflammation. This is the relation of different mechanisms to etiopathogenesis between NAFL and chronic kidney disease. Type 2 diabetes and metabolic syndrome. As you know, the centrally obese individual patients with type 2 diabetes and the insulin resistant are the most important risk factor to NAFL and CKD. NAFL as a metabolic liver disease, and the pro-inflammatory cytokines, or the increase of activity of renin, angiotensin, aldosterone system, and the oxidative stress mediated by pro-inflammatory prophylaxis mediators in relation with the two entities. This is a very interesting study with 4 phenotypes of patients with or without obesity and patients with or without metabolic health. You can see the patients with metabolic abnormalities, metabolic syndrome, and obesity were the patients that showed an increase of development of chronic kidney disease compared with the patients with obesity patients but metabolically healthy patients. This is a retrospective study of our group with patients with type 2 diabetes and chronic kidney disease. This is the baseline characteristics, patients with obesity and chronic kidney disease and proteinuria. We divide in 3 groups according to the NAFL score and the imaging tests. You can see the different groups. It's very interesting, this aspect of GFAR of this patient at the baseline. We can find the patients with group 2 and group 3 with fibrosis. The patients had lower GFAR compared with the group 1, and the proteinuria was increases in this group 3. The evolution of proteinuria and GFAR in 3 groups during the follow-up around 7 years, you can see that the very similar control of glycemia in this patient was very similar. The control of proteinuria was RAS inhibitors, but the problem was the renal function. The group 1 decreased 20 milliliters per person was 20%, and the group 3 was 47%. And the number of patients in group 2 and group 3 was higher, the percent of patients who developed end-stage renal disease compared with the group 1. Only the fibrosis was the only risk factor to develop chronic kidney disease in patients with diabetes, and the similar condition with the control of proteinuria in this group of patients. This is the Kaplan-Meier, and you can see this aspect about the what is the survival of patients who decrease 50% of the GFAR from baseline. In conclusion, this study asks the degree of hepatic fibrosis is a main factor to the progression of CKD, and probably should be included in the global evaluation of our patients with type 2 diabetes, and the presence of NAFL diabetic patients is a risk factor or renal progression. This is other study in our groups. These are patients with obesity undergone the bariatric surgery, and we analyzed only 54 patients. But the results was very significant clinical for us. This is the baseline characteristics of these patients. The majority was a metabolic syndrome, with a patient with a normal GFAR, and the percent of patients diagnosis with imaging was 70%, and non-invasive biomarker was the results. In this occasion, we could to show you the results of the liver biopsy and the fibrosis, and 35% of these patients had fibrosis in the liver biopsy. With compare the group of metabolic syndrome and non-metabolic syndrome was very similar conditions in relation with the age, BMI, GFR, proteinuria, non-invasive imaging, and the liver biopsy in both groups. And the patients with liver fibrosis, you can see the different aspects, and the metabolic syndrome was very similar in both groups, and non-significant results between the patient with the liver fibrosis or no liver fibrosis. This is a preliminary result of our study, but compares patients with the gold standard is liver fibrosis. Other aspect is the diet. You know that fructose are used in our diet, and this is the effects of the fructose with this metabolic to uric acid, and is a main factor of the cardiometabolic disease, and this is the relation with the hypertension, fatty liver, diabetes, and renal disease. Other aspect is the dysbiosis and the disbalance of the different groups of bacteria in the intestinal of our population, and these bacteria sowed and produce the different pro-inflammatory toxins or acids that contribute to the chronic kidney disease and the liver disease. Other situation is the plateau activation as a mediator of the link between NAFL and CKD, and the plateaus are activated, different granules and pro-inflammatory cytokines, chemokines, and growth factor play a main factor to develop two entities. As you know, the premature aging and the age-related change, the old people is a risk factor for NAFL, but also for CKD, and the decrease of clotoprotein occurs with aging. For this reason, this is a near correlation between age-related changes and NAFL and CKD. Other aspect is the relation between phenytoin A and adiponectin. Phenytoin A is a glycoprotein produced by the liver, and in humans higher phenytoin A levels associated with obesity and insulin resistance. On the other hand, adiponectin is a protein secreted for adipose tissue. This is receptor adiponectin in the podocyte, and with 6 disbalance between phenytoin and adiponectin increase the proteinuria in the patients with the disbalance, and the patients show with fibrosis and inflammation. And finally, this is the relation between renal function and different genetic tests. PNPLA3 is a gene that encoding, and he's been recognized a major common genetic variant associated with the NAFL. And as you know, PNPLA3 is also high expressed in the kidney and may lead to lipid accumulation in the kidney. One step more is very important relation and to diagnosis patients with NAFL. Recently, I talked with the pathologists, and in a small number of patients, the patients had a proteinuria in the diagnosis or during the follow-up, and for this reason, it's very important to obtain urine of this patient to know the value of albuminuria. And patients with CKD, we need to know the nephrologist, what is the condition of the liver in the patients with type 2 diabetes or chronic kidney disease. This is the natural history of the liver. This is NAS and fibrosis and cirrhosis, and we need to establish different therapeutic treatment. What is the possibility to treat this entity? We talk about a bariatric surgery, the decrease of weight of this patient, or GLP-1 receptor agonists, or SLT2 inhibitors. When we decided to changing the diet of this patient, this is a good correlation with the decrease of grade of fibrosis of this patient. This is a very interesting study for the decrease or resolution of NAS of this patient and the increase of GFAR with the patients changing the lifestyle of the diet or exercise in patients with this condition. This is other study of our group, patients with CKD, obesity patients undergone to bariatric surgery. This is the difference during the follow-up of this patient, the decrease of total fat of this patient after bariatric surgery. This is the changing of GFAR. This is a limitation of different studies. In this occasion, our group designed this study to calculate the GFAR, the real GFAR, with different techniques by EASO. This is the real GFAR of our patients. And from baseline, the patient decrease of GFAR, and after during the follow-up, recover the GFAR. This is the relation with the hyperfiltration of this patient with obesity and chronic kidney disease, and decrease the proteinuria. What happened with the other parameters? This is the leptin decrease after the bariatric surgery. That you remember the leptin increase the side renal effects, and the adiponectin increase after bariatric surgery. The evolution of NAFLD score in these patients, at the end of the study, the change of the score was 3.3, 3.4, one patient from 4 patients, and 4 patients decrease of fibrosis in 7 patients at the end of this study. The reduction of fibrosis from 0.3 to 1.4. The decrease of inflammatory cytokines, the interleukin or other inflammatory parameters after the bariatric surgery. This is the end of results before to bariatric surgery of our patients of different aspects of the baseline, and showing changing the colors, the red colors to green after the bariatric surgery in our patients. SLT2 is the new drugs about the relation to the cardio and nephroprotective studies on our group of the obesity working groups. This is a review of the different aspects of GLP-1 and SLT2 inhibitors. Recently has been published the effects of SLT2 inhibitors in the 2 HERC outcomes, the effects of the renal function and the cardiovascular event, and decrease of mortality, decrease of cardiovascular events. This is the effects of SLT2. SLT2 inhibitors has an effect of a decrease of NAFLD in this patient. There are some studies about this relationship, and GLP-1 agonist receptor has a direct effects, nephroprotective and cardioprotective effects, and finally have a beneficial effects on the cardiovascular disease in this group of patients. This is the future on the different molecules on different targets to develop the beneficial effects in the two entities, the NAFL and the chronic kidney disease. And finally, this is the take-home message. Recent study has suggested that NAFL or MAFL is associated with increased risk of CKD, but we need more confirmation on prospective studies. Increased body evidence to talk about MAFL because it included metabolic syndrome in this name, and the inflammatory cytokines, oxidative stress, activation of RAS, insulin-resistant intestinal microbiota dysbiosis were reported a potential pathogenesis. It's very important to screen it in patients with CKD, the NAFL, and patients with NAFL screening of CKD. For the reason because there is an interrelation between two entities. The way those GLP-1 receptor agonists or SLT2 inhibitors may benefit both liver and the kidney in these patients with two entities, MAFL and chronic kidney diseases. For this reason, it's very important to work together in these multidisciplinary teams. Thank you very much for your attention. This is a Spanish singer in the last tour about the end of the singer life. Thank you very much for your attention.
Professor Morales, thank you very much for this excellent talk. We added now fatty liver into the session, and the talk reminded me of adipocyte, kidney, and liver crosstalk. Well, I'm going to the third talk now. And the third talk will be given by Professor Muscojuri, a professor of endocrinology at University of Naples, Federico II, and she works as a member of a EASO collaborating center for obesity management at the same university. Her main research interest is obesities, including monogenic obesity and syndromic obesity.
Good morning, I am Giovanna Muscojuri and I am Assistant Professor at University Federico II of Naples. My title speech is Fatty Kidney and Obesity. So, as you know, obesity is a chronic relapsing progressive disease and it is a multifactorial disease. But mostly obesity is a social disease involving the overcoming of stigma, discrimination and generalization. As you can see here, there are the definitions of obesity made by different scientific societies. And as you can see here, the most reported word was chronic. So this in order to highlight that obesity is a global chronic disease requiring long-term management. And obesity is also responsible of the increased risk of mortality. And there is also an estimated effects of the BMI that would be reached by about 60 years of age on survival from age 35 years, identifying European Union mortality rates In 2000, with those for BMI 25 to 30 kilograms square meter, and combining the disease-specific EU mortality rates with disease-specific relative risks. The absolute differences in median survival should be robust to changes in mortality rates and therefore generalizable degradates in 3 main and 2 higher BMI categories. The 2 higher BMI categories account for just 2% of PSH participants, and so are indicated by dashed lines. Excess adiposity typically evolves slowly over time. Some of the pathways leading to the genesis of excess adiposity, by which the mechanical, metabolic, and physiological effects of excess adiposity led to coexisting chronic diseases. Elevated levels of free fatty acids, inflammatory cytokines, and lipid intermediates in non-adipose tissues contribute to impaired insulin signaling and the insulin-resistant state that is present in many patients who are overweight or obese. With excess adiposity, liposomes in hepatocytes can increase in size, steatosis, forming large vacuoles that are accompanied by a series of pathological stains, including NAFLD, steatohepatitis, and cirrhosis. Heart diseases, stroke, and chronic diseases all have as their main pathophysiological mechanisms high blood pressure and the cluster of findings associated with insulin resistance, obesity-associated dyslipidemia, and type 2 diabetes. Obesity is often accompanied by an increase in pharyngeal soft tissues, which can block airways during sleep and lead to obstructive sleep apnea. Excess adiposity also imposes a mechanical load on joints, making obesity a risk factor for the development of osteoarthritis. An increase in intra-abdominal pressure accounts for the elevated risk of gastroesophageal reflux disease, Barrett's esophagus, and esophageal adenocarcinoma among persons who are overweight or obese. Obese individuals can present with a wide range of medical and psychosocial problems, which can promote weight gain, provide important indications for treatment, but in some cases also pose significant barriers to management. To ensure a complete assessment and consideration of these factors, I propose the use of a simple mnemonic consisting of 4 MS or MMM and M that stand for mental, mechanical, metabolic, and monetary respectively, and may help the busy practitioner navigate it through a true assessment of clients presenting with excess weight. However, there are no mention on kidney. So what about kidney? There are the study examining the association between obesity and chronic disease. As you can see here, subjects with obesity are more prone to develop microalbuminuria and at an elevated risk of developing kidney disease. The need for enhanced energy storage in expanded adipose tissue depots results in adipocyte stress, which triggers a local inflammatory response and cause adipocyte dysfunction. The release of factors associated with the sodium retention in the kidney, such as leptin and angiotensinogen, led to hypertension. Sodium retention in the kidney is further augmented by local increases in cortisol, which binds to mineral corticoid receptors in the kidney, and by the mechanical effects of increased perirenal and renal sinus fat accumulation, which result in compression of the renal vein and the reduction in the tubular flow rate. Increases in adipocyte lipolysis due to progressive insulin resistance result in ectopic lipid deposition in insulin target tissues, such as skeletal muscle, thereby increasing insulin resistance and impaired glycemia. Ectopic lipid storage in the kidney, alongside glucotoxic stimuli due to impaired glucose tolerance, promotes glomerular and tubular injury. These hypertensive, lipotoxic, and glucotoxic stimuli coincide with the reductions in the adiponectin release from adipocytes, a factor implicated in podocyte-mediated tonic maintenance of glomerular perm selectivity. Hyperfiltration and defects in glomerular permeability promote kidney cell stress and inflammation, which results in tubular dropout, glomerulosclerosis, tubulointerstitial fibrosis, and ultimately led to a decline in kidney function. So, as you can see here, weight loss may improve obesity-related comorbidities, and benefits there are for 5 to 10% weight loss. And this small reduction of weight is also accompanied by improvements in blood pressure that, as you know, has also a beneficial effect on kidney. So there are several current obesity treatment guidelines, and clinicians that treat patients for overweight and obesity have a variety of guidelines that are available to them to guide and inform their practice. The guidelines presented here represent the recommendations of a number of different societies and associations from the US. These are the EASO European Guidelines for Obesity Management in Nodules 2015, and as you can see here, there is different treatments for different range of BMI, and the use of drugs are recommended for men when there is a BMI ranges from 30 to 35, and for both women and men for BMI from 35 and also higher than 40. However, drugs are always recommended when there are obesity-related complications. Here there are the EASO European Guidelines for Obesity Management in Nodules, and this is the algorithm. You should assess symptoms and causes, complications, lifestyle, motivation to lose weight, set goals that usually are 5 to 10% body weight loss or 0.51 kilograms per week. Manage weight loss. Consider specialist referral if complex disease states present, conventional treatment fails, or bariatric surgery is being considered, and emphasize long-term follow-up because obesity is a chronic disease. And in particular, the pharmacological treatment in patients is recommended when BMI is higher than 30, or is higher than 27 and it is accompanied by obesity-related disease. Pharmacotherapy should be evaluated after the first 3 months and continued if weight loss achieved is satisfactory or discontinued in non-responders. Lifestyle modification or very low-calorie diets can lead to modest weight losses of up to 10%, but with a great chance weight regain. Evidence suggests that intensive behavioral therapy can deliver the weight loss of 4–6%, and approved and available pharmacotherapeutic options can deliver weight loss in range of 3–10%. In contrast, bariatric surgery induces very large and sustained weight losses of 10–40%. However, only few patients are candidates for these invasive procedures. Therefore, there has been a treatment gap for the majority of patients requiring a clinically relevant weight loss, and newly approved pharmacotherapies together with lifestyle modification may be a suitable treatment option for these individuals. And as you can see in this trial, after 52 weeks mean weight loss in the IBT alone group was 6.1%. The IBT, liraglutide, and the multi-component intervention groups achieved significantly greater weight loss than the IBT alone group, with 11.5 and 11.8% weight loss respectively. There was no significant difference in weight loss between the IBT liraglutide group and the multi-component group. There are currently a limited but growing number of pharmacotherapy options available for weight management, and they are shown here. In Europe, only orlistat, naltrexone, bupropion, and liraglutide 3.0 mg are approved for weight management. In the US, there are 6 approved therapies: orlistat, phentermine for short-term use, phentermine, topiramate, and lorcaserin, naltrexone, bupropion, and liraglutide 3.0 mg. Sibutramine is not approved for weight management in EU or US, but might be used in some other countries. The therapies are licensed as adjunct to diet and physical exercise in people with a BMI of at least 30 kilograms square meter or 27 kilograms square meter with one or more comorbidities. A series of very potent derivatives of the 30 amino acid peptide hormone GLP-1 is described in this cartoon. These compounds were all derivatized with the fatty acids in order to protect their action by facilitating binding to serum albumin. GLP-1 had a potency of 55 ppm for the cloned human GLP-1 receptors, and many of the compounds have similar or even higher potencies despite quite large substituents. Microvascular events was lower in the liraglutide group than in the placebo group, and this difference was mostly explained by the lower rate of nephropathy events in the liraglutide group. And this is because GLP-1 is also able to have a direct actions on kidney because kidney expressed GLP-1 receptor. But also we can see that in the scale trials, the treatment with liraglutide was accompanied by a reduction of blood pressure, and this was another highly indirect mechanism that could explain the improvement of nephropathy after the treatment with the liraglutide. Another nutritional approach that is commonly used for the treatment of obesity is represented by the very low-calorie ketogenic diet. And in this study, the authors aim to investigate the efficacy and safety of well-CKD in patients with obesity and mild kidney failure. This prospective observational real-life study was carried out in 92 patients following a well-CKD protocol for approximately 3 months. 38 subjects had mild kidney failure and 54 subjects had no renal condition, and no clinical relevant variation regarding liver and kidney function. And upon stratification based on kidney function, no differences in efficacy and safety outcomes were found. Interestingly, 27.7% of patients with mild renal failure reported normalization of glomerular filtrate after dietary intervention. The need for enhanced energy storage in expanded adipose tissue deposits results in adipocyte stress, which triggers a local inflammatory response and causes adipocyte dysfunction. And as you can see here, there is a protective effects also of the bariatric surgery that is able to act on kidney through different mechanisms. We have bariatric effects with the reduction of visceral fats, but there are also metabolic effects that are mediated by their reduced hepatic glucose production, the incretin effect related to bariatric surgery, the increased peripheral insulin sensitivity, intestinal gluconeogenesis, intestinal glucose disposal, and improved lipid status. But there is also a reduction of leptin and insulin, a reduction of sympathetic drive, a direct natriuretic effects of GLP-1, decreased neprilysin, increased NAP, and decreased RAS activity. In this study, the authors investigated the effect of a bariatric surgery on the renal function of patients with morbid obesity and CKD. And you can see here in this prospective studies that included 13 adult patients with CKD, median GFR did not change significantly after bariatric surgery, although there was a significant decrease in the protein excretion rate at 6 months. An improvement in the GIGO CKD risk category was seen in 30.7 patients. In addition, there is this other study that was carried out in order to analyze the evolution of renal function, adipose tissue-derived molecules, and inflammatory parameters in patients with CKD after bariatric surgery. Observational and prospective study was carried out in 12 subjects with severe obesity, and there was a 24 months follow-up, and the main results of this study was that measured GFR significantly diminished from before surgery to months 24 after surgery. So my take-home messages are that obesity is a risk factor for kidney complications. Weight loss is able to potentially partially reverse obesity-related kidney alterations. Liraglutide, well-CKD, and bariatric surgery has been demonstrated to be renal safe tools for the treatment of obesity. And thank you for your attention.
Well, Giovanna, thank you very much. I think we need to close due to the fact that we passed the planned closure time. It was a very interesting, significant, and stimulating session. I think there are lots to do for the clinicians, clinical and basic scientists. I would also like to thank the EASO and the European Renal Association for their work in organizing this meeting. Thank you very much. The answers, I think, Sherry, Ewan, and Kathy will be forwarded to the participants as soon as they are taken from the speakers. Thank you very much.